amongst male inmates through football in correction facilities in Zambia, Malawi, and Zimbabwe. But before Michael and the other colleagues come on, I also wish to tell people that I'm Dr. Laston Chitembo from the World Health Organization. So I'll be moderating this session. If we are ready.
Go back a slide, please. Thank you.
Please, you have 10 minutes. Thank you. All the best.
Good morning, ladies and gentlemen. It's a pleasure to be up here today. Today, I'm going to speak to you about a project that was looking to improve HIV knowledge and gender-based attitudes among male inmates through football in correctional facilities in Southern Africa. Now, we've made a lot of progress in the fight against HIV, but many groups remain on the outside. Inmates represent one of those groups. They are often marginalized, disenfranchised, and left out of HIV-related programs. While Sport for Change is widely used across the globe, it remains unutilized and untested in closed settings in Southern Africa, despite providing an exciting mechanism to reach highly marginalized populations who are often left out of healthcare programming. So this presentation introduces the results of an innovative model to address the needs of inmates. Next slide. So a little bit about Tackle. We use the power and popularity of football to deliver SRHR programs to key populations and young people across 9 countries in Africa. Our bespoke curricula cover the whole SRHR spectrum with programs in a number of different areas depending on the target population's needs. We train networks of peer educators, coaches, and teachers to deliver educational SRHR football sessions to their peers. Now, as we don't have time for a physical demonstration, I'd like to just take you on a quick journey into a Tackle session to take you into our world. Enjoy. Play the video. Next slide. And play. Apologies for this.
Hi, my name is Margaret Ella of Taco Africa. We are learning about sexual health. If you want, come and join us.
I'm your coach, Coach Eddie. The name of the session is Don't Be Shy of
ICASA.
And our football topic is passing and moving. And the whole idea is that avoid the taggers tagging you. I want to see you now communicating. So communicate. Tell me that, coach, the tagger is behind you so that I'm aware, I know. The taggers that are putting on pink, they represent STIs. Successful passing represents condom use. When they tag you, it means you have what, guys? An STI, yes, an STI like gonorrhea and everything, but this time around, you have to stand with your legs far apart, and when the ball is stuck between your legs, it means you have gone for an STI screening and you've gotten treatment, and I now want you to happily join back your friends because you are now healthy. Legs apart, and you want to fit them. Can you tag her using a condom? No. Can she have an STI using a condom? No. Stop, guys, stop. Make sure, guys. How can you stay safe from STIs in this game?
By using condom.
And which one is a condom in this case?
That condom.
That's a condom, huh? You're sexually active. Let's make sure that we do what? We screen regularly for what? For STIs. Matagas over pink, it doesn't represent Chan. STIs, right? What kama basama langiza symptoms my STIs? What kama basama langiza?
Because women are growing up in a private society.
Okay. So guys, while that wasn't in the youth, while that was with youth population, it's the same methodology that is used in the inmates with the inmate population. So we use football as a vehicle for social change to engage people in their sexual health in a way that they enjoy, they remember, and they understand. So to introduce the project, in Southern Africa, incarcerated people experience higher HIV prevalence than the general population. This is compounded by the impact of separation from families, adverse effects on health due to unsanitary and overcrowded prison environments, as well as uncertainty over their future. This all negatively impacts inmates' well-being and their willingness and ability to take care of themselves, their sexual health, and their overall well-being. So this project was implemented in partnership with VSO, was a 2-year project across 14 correctional facilities in Zambia, Zimbabwe, and Malawi. Inmate coaches received 4-day training courses 3 times a year. Now, this is really important because this creates a cadre of peer educators who are able to share information outside of the sessions with their peers in the correctional facilities. They're able to share information that others may not want to take to prison officers or even the clinicians. The project was delivered as a rolling 10-week intervention. So what were the results? 126 inmate coaches were trained as peer educators, leaving a group of inmates who were able to deliver the sessions beyond the life of the project. Over the course of the project, we had prisoners getting in touch with us once they'd been released, asking if they could still deliver the sessions in their community as an opportunity to reintegrate, and so positive reintegration back into community life. We also reached 2,920 male inmates. Now, while they are not a part of this study, we also reached 300 female inmates. Over 1,000 football sessions were delivered with inbuilt health messaging. 1,200 HIV tests were administered. We also found that 80% of inmates shared the information obtained through the project with others. One really interesting aspect that we got from our external evaluation was that inmates reported that through participation in the program, they learned to value their own life and to share the information to contribute to the well-being of others. This idea of well-being came out really strongly throughout.
Michael, I think we have a problem. The slides don't seem to be moving. IT, please. Thank you.
Apologies. You can move to the next slides. Okay, so as I said, it was a 2-year project with inmate coaches receiving 4-day training, and it was delivered on a 10-week intervention. Next slide. So the results, I will quickly run through again. The 126 inmates were trained, 2,920 inmates were reached, over 1,000 football health sessions were delivered, 1,200 HIV tests were administered, with 80% of inmates saying that they'd shared the information with others in the project. They also shared that they, next please, apologies. They also shared that they had learned to value their own life and to share information to contribute to the well-being of others. Next. So looking at some of the knowledge and attitudes around SRHR, to assess the efficacy of the sessions, we conducted baseline before they'd started the session, as well as at the end of the 10th session. This graph shows the percent of respondents who'd answered correctly to all the questions. There's been an increase across the board, including comprehensive knowledge of HIV. Next. So, key takeaways. Consultants were hired to conduct an external evaluation. A cross-sectional mixed method evaluation design was used as the framework for sampling and collecting data. And here are some of the key takeaways. We had positive impact on knowledge, attitudes, and service use, changes in attitudes to SGBV, condom use, and HIV testing, increased commitment to well-being and reducing the risk of contracting, transmitting HIV, reduction in reoffending rates, and increased self-reported well-being. So the well-being has come up again. So whilst it wasn't intentionally a part of the conceptualization of the project, what we found is an unintended outcome. Improved resilience supports positive reintegration back to community, supporting longer-term health-seeking behaviors, including things such as ART retention. There was also enjoyment, exercise, improved relationship with officers, and community outreaches caused reduction in stigma and discrimination against former inmates. Next. So in conclusion, football-based interventions are an effective mechanism to engage with male inmates in Southern Africa around sensitive issues related to HIV, SRHR, and attitudes towards women. Inmate-led sport-based interventions represent a sustainable and valuable mechanism to engage with a highly...
Once again, the slides don't seem to be moving.
Next, please. Apologies. Next. Inmate-led sport-based interventions represent a sustainable and valuable mechanism to engage with a highly disenfranchised and alienated group that are critical to reaching global goals around HIV. So before I close, I'd just like to say that this project was not possible without support from UK Aid, Comic Relief,
Next slide.
please, and the BT Supporters Club, and valuable partnership of VSO, SANOP, and the respective correctional services in Zimbabwe, Zambia, and Malawi. Next. Got it right eventually. Thank you very much.
Thank you very much, Michael, for that succinct presentation, and you've kept the time. Please. Our next presenter is Priska Skana. Priska, please come. She's going to talk about promoting human rights, quality health, and well-being for youth prison populations. Priska has over about 15 years experience in media, policy development and analysis, gender equality, child and youth rights programming, and social inclusion. Also, human rights and activism. She's also been working with young people in prisons sector since 2020. Priska, over to you. IT, we are ready? You have 10 minutes.
Thank you so much. Good morning to you all. My name is Priska, as mentioned. So my presentation is on a study that was conducted that is focusing on promoting human rights, quality health, well-being for youth prison populations. But before I get in the presentation, I'd like to mention a bit about where I'm coming from. I'm coming from Southern African Network of Prisons, which is an organization that exists to serve the prison and ex-prison community and aiming to promote human rights and dignity in Southern Africa. We are currently working through Voluntary Service Overseas, which is VSO, and we're working within prisons and correctional facilities in Eswatini, Malawi, Zambia, and Zimbabwe. And one of our main objectives is to influence change around how our countries implement decisions and policies in correctional facilities, that they need to consider treaties and conventions that our countries have signed, such as the Nelson Mandela Rules and the SADC minimum standards for HIV, TB, STIs, hepatitis B and C. So I'll go straight in my presentation. That's a brief about where I am coming from. So as you can see, we conducted a study as SANOP in about a year ago, and the aim of the study was to actually look at the welfare of young people and migrants in correctional facilities around the region. And we wanted to understand or to assess the three domains of change at individual, community, and systems level to understand the status of the young people in correctional facilities in terms of their health and well-being. And the objectives of the study were to review and analyze the policies and the traditional practices affecting the well-being of prison populations, and also to find out the health challenges that young people in correctional settings were facing, and also to document their health practices and analyze their attitudes and knowledge, as well as assess the availability of youth rehabilitative services in the prisons and correctional facilities that we were going to target. And our study design was a mixed method, and it was done within an existing project. There was an ongoing project that we had to undertake the study, and it was an action-oriented research kind of. And our coverage in the study was, we focused on Eswatini, Zambia, and Zimbabwe. IT, next slide. Okay, and the next one. Okay, thank you so much. So yeah, we focused on Eswatini, Zambia, and Zimbabwe in about 19 correctional facilities and prisons. Next slide. And the study population was that we were in facilities where we had above 100. We were able to sample about 10% of the population. And in facilities where there was between 60 to 99, we were able to sample 30%. And where we had 25 inmates and below, then we sampled all the people that we found there. The next slide. And we now go into the findings. So from the research that was done, it was found that when it comes to availability of sexual and reproductive health services, in Eswatini, 79% of the respondents said they had sexual and reproductive health services available for the populations that we sampled, and only 21% said they did not have. In Zambia, 94% did say the sexual and reproductive health services were available, and 6% said they didn't. In Zimbabwe, 100% of our sampled population said their services were available. And overall, an average for the three countries, those that said yes, the services were available were 91%, with only 9% saying they were not available. Also note that some of the facilities that we sampled were remand facilities, apart from the other ones that were actual holding facilities. Then access to sexual and reproductive health services. So for Eswatini, about 70% said they had access to the services. And also in Zambia, about 86% said they had access. And in Zimbabwe as well, they did say about 75% said they had access. So there's kind of services that were topping the list were HIV testing and counseling. Then when it comes to other services, such as access to condoms, contraception, those were very low. For female facilities, also access to sanitary ware was quite low through the research. Then in terms of the barriers to accessing the services, there was a lack of youth-friendly spaces, there was an issue of stigmatization, and there was also issues to do with fear and lack of confidence for the young people to approach the health providers. Then there was also an issue of the health providers in the facilities not being trained to handle young people as well. Next slide, please. We can move to the next as well. Yes. Then in terms of challenges that they faced as young people, especially those with disabilities, it was that there was an availability of comprehensive sexual reproductive health. I think most of it was very basic, and also that the services or the spaces were not youth-friendly, and also the quality of services, because mostly they were general services that were being offered and not directly tailored to suit the young people that were incarcerated, and also the aspect of stigma. We can move to the next. Okay. So in terms of the quality of the services for rehabilitation, The services were there, but the quality, as we can see from the graphs, was Eswatini 75%, Zambia 65%, and Zimbabwe 100%. We can move to the next. Then in terms of the availability of platforms for young people that are in the facilities to express themselves or to discuss issues that affect them, the spaces were available, as you can see, and then the effectiveness of these platforms was also analyzed. And these platforms that exist usually are youth clubs, as well as committees that are formed, like health committees within there. But then the challenges are that those platforms, like the committees, the young people that represent their colleagues are appointed by the officers. So the young people felt, because it's an appointment, they're not electing their representative, then the effectiveness is compromised. Then we can move to recommendations. In terms of recommendations from the study, the first recommendation is that there's need to ensure that there's availability and accessibility of comprehensive sexual reproductive health services in the facilities for young people, specifically for young people. There's need for regular gender training and trainings on specific health issues, health needs for women and young people in correctional facilities. So most trainings that have existed are general trainings, but there's need to actually zero in on gender-specific kind of trainings for women and young people. Then there's need for more advocacy for the implementation of the United Nations rules for the treatment of women prisoners and non-custodial measures for women offenders. Apart from the implementation of the Nelson Mandela rules as well, there's need for advocacy for these other two as well. There's also need to lobby for crime prevention and rehabilitation policies in the three countries or just within the region, the Southern African region, so that we're not reactive, but then we are preventing our young people from getting into these facilities. Then also establishing of safe spaces for young male and female offenders, for them to be able to voice and be able to represent themselves. Then also the establishment of structures or facilities for rehabilitation and reintegration of youth offenders at every level. Also the provision of starter packs for young people when they're out of prisons or correctional centers, so that we prevent the issue of reoffending, so that they don't come back as adult offenders, which has been a trend in some of our countries. Then also the strengthening of youth voices in correctional settings. In conclusion, I would like to say that while in all the correctional facilities that the respondents indicated that the services are there, it's imperative that we need to look deeper into what is available, what services are available, and how they are accessible, and the quality of the services being given to young people. And also, there is need for us to also look at the limited service delivery that affects the general health and adherence to ART in the facilities. Also, the findings also provide a guide for us as stakeholders to improve on SRH provision. Thank you so much. Thank you, moderator.
Thank you. Applause for Priska. No, that was an interesting presentation and findings. Our next presenter is Juma Kwame Mhina from Tanzania. Is going to talk about scaling up harm reduction services for people who inject drugs in Tanzania, reaching last mile for people who inject drugs in people who inject drug communities. Who is Juma? Juma is a drug user activist since 2013, the past 10 years, basically, advocating for accessibility, addressing issues relating to stigma and discrimination, human rights protection. Currently, is the director for Tanzania Network of People Who Use Drugs and promotes the meaningful engagement on issues regarding legal policy reforms and removal of barriers to access, as well as harm reduction and related health services. Juma, over to you.
Thank you very much. Good morning, everybody. Our study, as has been mentioned, that is concerned on the scaling up of harm reduction services to Tanzania people who inject drugs. Actually, we made a study for the people using drugs and the concern of the availability of the services of harm reduction, and also about the accessibility of those harm reduction services. Actually, we went into the background and we see that Tanzania has a coverage of 19.40 people who injecting drugs were receiving needle and syringe program services, and actually 41.20 people inject drugs are receiving MAT services respectively. But this is actually below the WHO recommendation of minimum 80% for the NSP and the 50% for the MAT coverages. But in the concern of the population of people inject drugs in Tanzania, from the 2022 data, we have 50,000 people inject drugs, but only 23% are receiving those services. Next. That is the title. Next, please. This is a message that which we used for the community-led study, whereby we used mixed approaches, looking at it was the period between January and June 2023, in order to identify the gaps in access and the quality of harm reduction services, which we did in 19 districts in the country, but also in the 2 police posts and 2 prisons in the Dar es Salaam region. And from that, they did the method of quantitative data, whereby collected using the questionnaire, and the qualitative data, which was collected through the focus group discussion with the people injecting drugs, and also had the key informant interview. And the data variable include information on service availability, challenges experienced by clients while accessing services, and clients' recommendation for service improvements. Next, please. These are the findings which we came after the study, and in accordance to the mixed approach which we used in conducting the study. And we identify gaps in access to quality of harm reduction services. We identified some gaps whereby the findings show that 41% of the respondents had no knowledge of harm reduction services in terms of MAT and the needle and syringe program services. But 70% of harm reduction clients indicated that they were satisfied, and 30% of the respondents were not all satisfied concerning the services which were being delivered to them. And 73% of the people inject drugs had challenges with issues of law enforcers, police, and other authorities. But moreover, mass service, the coverage of 41 and 0.20%, while NSP is only 19 and 4.0% in terms of coverage. But we also have some prison settings whereby they're receiving harm reduction services. For example, in Dar es Salaam, we have the Segerea prison where the MAT services is located there. And some of the inmates where people injecting drugs are receiving services at the prison. And also, lastly, we had another prison at Morogoro region called Kihonda district, whereby also prison inmates whereby unable to receive the services there. Next, please. Conclusion and recommendation is that 41% of the respondents, the current scope of harm reduction services is quite small, even though that we have some harm reduction services going in our country, but we as a community of the people injecting drugs, we see that there's more need expansion of these services in our country. So we recommend that our country, in order to invest in strategies that would reach the last mile people inject drugs with these harm reduction services. But we also look ahead for establishing like mobile outreaches, example for the MAT services and the take-home doses, so that in order to reach the last field mile for this harm reduction service. Also in prison, we think that the more need scaling up this harm reduction program to other prison settings and also to the needy regions. So scaling up of harm reduction service to reach the last mile will not only improve the well-being of the people inject drugs, but also contribute to the reduction of new HIV infection among the people injecting drugs community in Tanzania. So I believe that harm reduction save lives for the people who inject drugs, and by scaling up these services, we'll be decreasing the number of the prevalence of HIV transmission for the people injecting drugs. Thank you very much.
Thank you. Applause for Juma. Juma, you did a commendable job, man. You kept the time. So, ladies and gentlemen, I think it's now your show. You've listened to the presenters, um, Matthew, Juma, and Priska. So it's now time for your questions and clarifications. I'll start picking hands from the left, going right side. So please go ahead. Do we have any mics around? We start from the left side, we move this side. We have about 15 minutes. If there's no mic, please, if you can just speak up loudly so that we can save time. Perhaps, oh, you come over here. Okay, there's a mic coming. You just briefly introduce yourself and make sure you summarize your question.
Thank you,
Perhaps-
Mr. Chair, and thank you, the panelists. I am Dr. Peter Mdiope from Uganda. I chair the National Task Force for Harm Reduction. I just want to ask James one question. What is the policy platform for harm reduction in East and Southern Africa? Any literature on what's going on and how best we can address it? Thank you.
Thank you so much. My name is Edith. My question is to Matthew. From your findings, we had 1,200 HIV tests administered, but you have not told us about the results. Can you maybe briefly share that with us? How many were positive and what happened to those prisoners? Thank you.
Hi, thank you so much. My name is Yasmin Dunkley from the London School of Hygiene and Tropical Medicine. My question is also to the Tanzanian colleague, and it's just brilliant to see the network leading the presentation here. So thank you so much for sharing your insights. My question is, what more can we do regionally to echo the question here? And also in terms of the challenges that you faced as a network delivering services, what insights can you share for some of our other country stakeholders who have yet to establish networks of people who are injecting drugs to deliver services in the region? Thank you.
Thank you. We pause there for questions. Let's get responses. I guess the first question is for all three of you, then Matthew and Juma. Please, anyone can start. What you guys?
Sorry. In terms of the first question, I think I can only speak to Southern Africa at the moment. I think I can't speak too broadly or in depth about the policy. What I can say is that we need to look at the issues around kind of condom distribution in prisons to support inmates to take care of their sexual health, because whilst we look to turn a blind eye to what might happen in the prisons, we need to make sure that we are taking a public health approach and giving the opportunity to access condoms if they need them.
Thank you very much for the question in terms of the challenges facing as a network for the drug users. First, I can say that we had a lot of challenges faced when establishing this network, actually, because of the laws in our countries, whereby there are much more some criminalized laws, whereby the drug users actually, the small possession of drugs in the country is actually contrary to the law. But actually, we did much advocacy with the different allies also in our country and outside the country. And we had a different capacity building when establishing this network. And I can say that the challenges are not anymore. They are still in a lot of challenges because we're still facing a lot of law enforcers issues, but we are still striving to advocate and see that people injecting drugs in our country having the better services and the human rights issues are concerned. So that's what I can say.
Okay, I think for us, for what I can say is when you look at issues around harm reduction, I think they're very important and critical in the region because those are usually the people that we find in our correctional settings. So I think for countries like ours and within the region, there's been a push towards working on rehabilitative services rather than following the criminal route. And like in Zambia, for example, I think what's happening is that there's also access to private services now, which most people feel more comfortable, and also civil society supported platforms for support in terms of rehabilitation, and also diversion for young people. We now have the Children's Code Act in Zambia, which is a law that is supporting diversion instead of taking young people to correctional settings. So when a young person is diverted and they are injecting drugs or they're found with any of this, then they are able to get also access to rehabilitative services. Thank you.
There was a question about your view about Eastern and Southern African countries in terms of policies and laws. What's your overall picture?
I can say in terms of the policies of harm reduction in the Eastern countries, Southern African countries, because it's a little bit challenging because as an African countries, we when we go to the international treaties, whatever, we go and commit ourselves. But when we come back to the regional level, it's a little bit challenging in implementing these harm reduction policies or treaties. And it look like there's a difference between one country to another country in terms of the policies development. So you can see some of the Eastern countries like us, Tanzania, harm reduction services there, they're available, and we are pushing ahead for scaling up. But you can see some of the other countries in Africa, there's still a lot of challenge, even there's no any harm reduction services or any harm reduction activities. But in terms of policies, even our country, we have not come up with the harm reduction policies, which is a very unified one, and also a unified policies for the all African countries. So that's what I can say from my side.
Thanks, Juma. We can go for the next round of questions. We keep moving. Oh, yeah. Okay, please go ahead.
Good morning. My name is... Sorry, can I
I just
go?
want to answer the question that was asked before to me. So in terms of the test that administered, we had 15 new positives, and they were all referred to care. So it's worth bearing in mind that prisoners, when they enter the prison, are tested for HIV. So these are people that have most likely contracted HIV whilst inside the prison.
Okay, I know I said we start from left. Can we try to move? Because I know we won't get there. We're running out of time. Perhaps we move to the middle area, unless we'll get back to you. We'll get back to you.
So
anyone in the middle area, we'll get back to you.
Yes, I'm one.
Yeah.
That's me. Yeah,
Please.
so I just want to first congratulate our presenters. I think you have done a good job in an elaborate presentation. My question would be, are there any advocacy activities that are done around influencing policy so that programming done in prisons for the prevention of the spread of new infections can be attended to?
Thank you. Next question. Yes, go ahead. Over there.
Good morning. My name is Peter Ngogi from Kenya. So I want to appreciate the presenters for the nice presentation for the abstract. So my question goes to, I can't remember the lady, the study about that was done in Zambia and Zimbabwe on issues of sexual and reproductive health. So you have given us the data on services provided. What about commodities? What was the finding for the commodities within the prison? Did you find provision of condoms, the lubricant, or are we assuming they are not having sex within the prison? And because if the government is providing condom for the general population to prevent HIV, what about within the prison? What's the government doing? Thank you.
Thank you. I think let's get the mic this side. This side, please. We get the final questions, but we'll see if we're gonna have more time, then we can still take a few more questions. Over to you, colleagues, this side.
Thank you, Mr. Chairman, for the opportunity. My name is Okiwu Henry from Utrise, Nigeria. I kudos to all the presenters. I want to be brief. My question is, in terms of female who use drugs, what are the gender what are the gender issues among this subpopulation of women who use drug? And in terms of assessing services, how many of them are we seeing within the harm reduction program? Because there seems to be a hidden population inside a population that is driven underground. Thank you.
One more question. This side. Okay, get set. Let's get responses.
Thank you. Yes, I'll start with the question from the gentleman. Actually, when it comes to commodities, it's really, we're working in a very, very difficult environment. As you can see, most of the countries within our region do not allow the Prison Act or the policies that they have do not allow for the provision of condoms, lubes in the facilities, and those that are providing, they're coming from civil society and not really procured by government. So there's need for a lot of advocacy to get past that. If the numbers of HIV positive people are more in correctional settings than the general population in most of our countries, then it says a lot. Then there's need for advocacy around changing of our laws so that there should be provision of commodities such as condoms. HIV testing kits, you find them, and all these other commodities. But when it comes to some of these, like condoms, some of them are not being provided. There is also the aspects that we are trying to push around the regional approach, that maybe as SADC, as Africa, how do we utilize the existing platforms for advocacy? How do we utilize the African Union, the SADC, to push for the implementation of the United Nations Mandela rules and others, so that there's equal access to these commodities, even for our colleagues that are serving in these facilities. Thank you.
So thank you very much. The question concerning the advocacy activities, which advocacy activities we are doing. Actually, we as the Tanzania Network of People Using Drugs, we are doing regular advocacy activities. Example, now we have a Compass project, which is much more concerned in scaling up the harm reduction activities in the needy region and in the prison settings. Even though that the bigger problem comes in terms of the availability of fund for the scaling up of these harm reduction services, it's more a bigger problem we have been seeing. So we much more depend on the global fund and the paper fund in scaling up this harm reduction activities. But also we are advocating to see how we can have the local investment of the regional investment in our African countries, for example, through the African Union or through the SADC or the East African Cooperation. We can have our own local funds also, can see how we can invest in these harm reduction activities, because we have seen a lot of challenging and the issues of transmission of HIV/AIDS in the prison settings. Even though I can applaud my government through the Drug Control Enforcement Authority, we in Tanzania, through our advocacy, we've been able to establish 2 prisoner mat services settings, whereby prison are directly receiving the mat services over there in the 2 regions of Dar es Salaam and Morogoro. But we are not saying that it is enough. We are still pushing ahead to see that the more scaling up of these prison settings, mat services should be available in our country. On the issues of the women who inject drugs, we see them as a very special groups, because even in the data available for the women accessing services,